This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Clinical Neurology and Neurosurgery titled Predicting Dementia Severity Changes After Shunt Surgery for Idiopathic Normal Pressure Hydrocephalus, Role of the TAP Test and Cognitive Assessments.
This is a topic that hits home for anyone covering a busy adult hydrocephalus clinic. We all know the classic triad of iNPH: gait disturbance, urinary incontinence, and cognitive decline. But the real holy grail for us as surgeons is accurately predicting who will actually improve after we've placed a shunt.
Exactly, Dr. Aris. While gait often shows the most visible improvement, dementia is much trickier to predict. This study specifically aimed to determine the most appropriate assessment scale and, perhaps more importantly, the most effective timing of the TAP test to predict those post-operative cognitive changes.
Right. Traditionally, we perform the TAP test and look for immediate results. But let's dive into the methodology here. What scales were they comparing?
The researchers looked at several tools, but the focus was really on the comparison between the MMSE, the Mini Mental State Examination, and the FAB, or the Frontal Assessment Battery. They also utilized the iNPH grading scale, or iNPH-GS, to track overall symptom severity. They followed patients undergoing shunt surgery, whether it was a ventriculoperitoneal, VP, or lumboperitoneal, LP shunt.
Now, for the residents listening, why the FAB? In iNPH, we often see a subcortical or frontal pattern of dementia. The MMSE is a great general screen, but it sometimes misses the specific executive dysfunction we see in these patients.
That's a great point. The study found that when it comes to predicting dementia severity changes after shunt surgery, the frontal assessment battery was particularly sensitive. But the real clincher in this paper was the timing of the assessments after the TAP test.
This is the part that should interest our residents the most. In many institutions, we do a TAP test and assess the patient a few hours later. What did this study find regarding the timing?
The researchers evaluated the cognitive response at multiple intervals: 24 hours, 48 hours, and 72 hours after the cerebrospinal fluid TAP test. Their data suggests that the predictive power for long-term shunt success wasn't actually at its peak in those first few hours.
This is a crucial shift in thinking. If we only look at the 24-hour mark, we might be getting a false negative and denying a patient a shunt who would have eventually shown a response.
Precisely. The study highlights that the 72-hour mark after the TAP test provided a more accurate reflection of the patient's potential for cognitive recovery post-surgery. It seems there's a delayed physiological response to the pressure changes that we need to account for.
It makes sense. It takes time for the brain's periventricular white matter and frontal circuits to recalibrate after we've removed that volume of CSF. So, to summarize for our practicing surgeons, we need to be patient.
Exactly. And we need to be specific with our tools. The study concludes that the frontal assessment battery, or FAB, used in conjunction with this delayed 72-hour assessment window is a superior way to predict which patients will see a meaningful reduction in dementia severity.
It's about maximizing our predictive value. We don't want to subject an elderly patient to a surgical procedure with all the risks of infection or overdrainage if there's no benefit. Conversely, we don't want to miss a responder because we were too quick to judge the TAP test.
It also reminds us that the iNPH-GS, or grading scale, is a vital part of the baseline, but those specific cognitive batteries are what give us the granular data on dementia.
Very well put. For the medical students listening, remember, idiopathic normal pressure hydrocephalus is one of the few reversible causes of dementia. Studies like this, focusing on the TAP test and cognitive assessment timing, are what help us refine our surgical selection.
It's a move towards more personalized neurosurgery. By identifying the right scale and the right timing, we improve the quality of life for a very vulnerable patient population.
Well, that's all the time we have for today. A big thank you to the authors of this 2026 study for providing some much-needed clarity on the TAP test.
Thanks for joining us. We'll see you next time on the Neurosurgery Hub podcast.